right now. So this is Germany. I actually live in Hamburg up here, which is also where Ethicon has the research center for meshes. So all the mesh development within the company is done out of Hamburg. We also have the largest manufacturing facilities for meshes. It's actually also out of Hamburg. So all the physio mesh and all the UHS and all the other stuff, it's being produced there and was also developed. You know the country. I'm actually originally from a town called Hanover, which is about here, so just a little bit south of Hamburg, which actually has quite a good and well-known medical school and teaching university.
Transplant center.
Yeah. So, and this is just Hamburg. A few words about the city of Hamburg. It's actually an old city. It was founded in the 9th century, so it's over 1200 years old, almost 1100 something years old. And it's actually known for the port. It has the second largest port in Europe, followed by only Rotterdam is larger. And our research center is actually just outside of the city border of Hamburg. Hamburg is what we call a city-state. So it's like Washington, D.C. in the United States. It's a city, but it's also a state in itself. So one of two, actually three, we have in a country, Berlin and Bremen being the other one. So this is the city of Hamburg. Really known for trade in the international flavor because of the port. Okay, that being said, I didn't come here to talk about the city. But actually, you've probably seen the title of the presentation that I didn't come up with that title. When I was invited, the title was already there. So I guess that's what I'm supposed to talk about, and I do my best to talk about the past, and where are we today, and then maybe a little bit the future of hernia, which is just really a couple of questions. And in talking to some of you, the questions I have are obviously questions that you have yourself. And again, feel free to ask me any questions in between. But keep in mind, the more questions you ask, the longer it's going to be. My promise is the 20 minutes with no questions. If you ask questions, it's going to take a little longer. Actually, the past of hernia surgery is actually quite interesting. If you read some books and look into the history, you can actually find 1500 before Christ. You can find, if you look at some Egyptian stone inscriptions, you can actually find the earliest indications of that people were, and proof that people were actually looking at hernias 1500 before Christ. So that's quite impressive. 3,500 years ago, you find this, and you see a second example here of a Greek terracotta. Again, here's the hernia. You see this is 900 before Christ. So actually quite impressive how early people were clearly talking about hernias, because there's no way this and also this is anything else. It's a hernia and it's also encrypted in the stones. Also in Phoenician terracotta, a little bit younger, but still 400 to 500 years before Christ, you clearly see people are talking about hernia again. And then you do a little bit of a jump, about 1,000 or so years, and you go into the medieval times. And yes, you see the Middle Ages, you see a lot of pictures that actually show hernia surgery and hernia operations. And this is actually a nice quote I found, which is right here. I just put it here again, so it's a little bit larger. This is the hernia surgeon back then saying that, okay, so my art always gives safety to your life, and I use all care for your wound. And if by my industry you recover your health, pay honestly the fruit of my work. So he's making the statement that if I do good work, I want you to pay me for that.
Until today the same. Until today the same.
Say the same today, right?
But pay more.
Again, I was just looking through old books and old pictures. Actually, quite interesting what you can find in the literature. This is a surgeon again showing a unilateral and a bilateral hernia procedure that he has done to his students. Right? So he did both procedures and is showing it and explaining it actually to his students. This one is a prolapse fecal fistula, as you can see here, after a strangulated hernia, and that's in 1650 or so, also quite interesting. This again, strangulated hernia, this is 1820, so I'm just going times quite interesting pictures you can find in the medical literature if you look at this. This actually is a huge hernia actually here, held by a shoulder strap. And this is how people were walking around. Imagine people doing this today, but this is really a huge hernia, obviously, as you can see here, and the way they were treating it, or at least taking it. This also I find interesting. This is a hernia operation actually showing how the inverted position of the patient on a, so to say, table. What was the table back then was a piece of wood. But you can see how they were actually treating the hernia and basically putting the poor guy upside down. And even worse here, so this is the way of actually the ancient upside down treatment. So they're really putting the patient upside down, hoping that this would help them getting rid of this strangulated hernia again. So actually quite interesting. And some instruments people were developing back then. This is actually called a Spenton's instrument. I don't know if you've seen it before. For me, it's a corkscrew screwdriver to open wine bottles. But it was actually invented or used in 1890, and it was actually used to treat an inguinal hernia, as you can see. And then you've probably seen all those different kinds of belts and bends and straps that are still being used to some extent today. In some cases, obviously, they look different today. But it's actually quite interesting what you can find if you just go through it a little bit in history and how hernias have been treated all along for many thousands of years, I should say. Okay, here's actually, and this kind of leads me over, and I know you can't read the text. But this is from the original Liechtenstein publication where he talked about his Liechtenstein repair and using basically, it says, a polypropylene mesh to actually close or cover the defect. So this leads over to the, say, modern times of hernia surgery. So this is a little bit, I guess, the past I wanted to talk about. Hopefully you find some of those pictures as interesting as I found them when I looked through the books. So obviously, you know all those people, you know all those techniques. It's just trying to get us to where we are today, and then we talk about the way I think we should be looking at hernia surgery today. So you see all the famous names on here. You should see in a number of the different techniques that have been developed all the way from the medieval times really to basically today. So yeah, this is going to kind of like close a little bit the past of hernia surgery, and how it looked, and how long we've actually been looking at those cases from a medical perspective. What I'd like to talk about today is the way we look at hernia surgery today. And some of you may be disappointed, but hopefully not. In all of my presentation, there's not going to be a single product mentioned. So this is not an advertisement for Ethicon's products. I just want to talk about hernia a little bit, and I want to do it from now on from a scientific perspective. So I want to talk about evidence, I want to talk about data, I want to talk about those kind of things. I don't want to sell Ethicon products to you. I leave it up to my colleagues to do this, so you won't find any Ethicon product nameless in the presentation. And if we just start doing this, we would actually, everything that comes from now on, we haven't developed by our own. We had actually support by a number of very well-known and well-respected hernia surgeons across Europe. I guess I heard Joachim Konze is going to be here tomorrow. He's going to give a talk tomorrow. You're going to see some of the information you see today tomorrow, but he's going to give it a different spin because he's the surgeon talking, not the R&D guy talking, right? So, but he obviously was one of the supporters of what we're doing here, and a lot of other people did this. This is not just the 5 listed here, even though they were main contributors. There's also, you know, a lot of discussions and meetings and things like that, advisory boards with people just like you that went into developing what you're going to see in a few minutes. So I guess you've seen this, right? I mean, if you really start now talking about mesh, you know, it's a multifactorial challenge. It has basically 4 aspects that need to be considered. One obviously is the patient, the other one is the surgeon, and then surgical technique, and obviously mesh selection. And you can spin it any way you want. Those are probably the 4 main factors you have. And being the guy who develops meshes, the one I'm going to talk about obviously is the mesh piece of this. So, and this is what you hear people say that, I mean, if you look at hernia surgery today, as you all know, chronic pain, so post-operative chronic pain is the primary reason for dissatisfaction patients have with their hernia surgery, right? And this is obviously, as you know, about up to 40% of all the people who have been treated say this, and this is backed up by a number of studies which are listed down here. You see the numbers here. You see the differences between incisional, where it tends to be a lot higher, and inguinal or groin hernia, where it's a little bit smaller. But on the whole, you see there's little too many people today who complain about post-operative pain to me. So obviously, back to meshes, we know today, I'm going to show you some of the data we have, that obviously the selection of the mesh, outside of the other factors, the patient and the surgical technique and so on, does have a big impact on those factors and on the pain that people have most often. And you know how all this started. I mean, this is the Professor Schumpelik, probably a lot of you know. He was the one who actually, together with us as a company many years ago, started thinking about hernia surgery and how we could potentially do better. And you know that he is, so to say, the father of the partially macroporous resorbable mesh kind of like concept, right? He was the first one who had those ideas, and we did a lot of development with him and his group. And you know that Dr. Konz, who is going to be here tomorrow, he was obviously on Professor Schumpelik's team back then. So I guess part of the issue is that when you implant a mesh, as we all know, is the integration of the mesh, right? So how well does the mesh integrate into the body? And obviously, what always happens when you put a foreign body into the human body, you always get an inflammatory response. It can be more or less severe, but you're always going to get it, right? There's no way around it. And so what you can see here, those white fibers are basically the mesh strands, the mesh fibers, as you all know. So everything that's kind of like in the white area here is mesh. But then just around this, you can see the inflammatory response that the body always has to things being put into itself, right? He doesn't like it, so it's always an inflammatory response. And then on the outer side, you get what we call the outer granuloma, a fibrotic reaction, fibroside. That's part of the integration of the mesh, as you all know. So that's the good part, and the other one is the not so good part, but unavoidable, right? So that's and then there's also the pictures that quoted here, taken from Professor Kloster. So, and if you just think about this, the granuloma formation that we have in two different ways, obviously it leads to different things, right? Or it affects different things. One is obviously the compression of the tissue. I'm going to talk about it more a little bit later. Obviously some stiffness of the mesh, and we'll show you examples. Seroma formation or nerve entrapment, potentially infection, those can be all risk factors associated to how well the body responds to the mesh or not. So here's actually a little movie. You've probably seen this before. You can see in mesh, and you see how it's still fixated okay, but what we see here is actually passive compression. So the mesh has shrunk so much from its original size that if you didn't have sufficient overlap, you'd have a recurrence right here, because the mesh right now is so much smaller than it was originally. Right? So those things that we just talked about are very important when you place the mesh, when you select. So here you see the original size of the mesh, and this is actually what's left after explanting the mesh. So this is, I would say, probably a 48 says up to 50%, about a 40 to 50%. And actually it's not a shrinkage, because if you call it shrinkage, it implies that the mesh is shrinking. The mesh is not shrinking. It is the tissue around the mesh that compresses the mesh, because all the reaction is the body and it's the tissue, it's never the mesh itself. The mesh is just integrated, so it kind of like shrinks with it, but it's actually a compression from the outside, which is, we talked about that, which is why the mesh selection is so important. So you make sure the compatibility with the human body is as good as possible. Okay, so you see this, and probably like this by now. So you see how dramatically the size has changed in this piece of mesh. And this is the opposite. You have seen that by now, shown at almost any congress. This is a piece of mesh, and as you can see, when the surgeon is touching it, it's extremely rigid. It's almost like a rock. It's not a rock quite like a rock, but it's definitely, I mean, imagine you have this in your groin and you bend and you lift things, you can feel it every day. Every day, if you have a piece of mesh like this, you can feel it every day. And that's obviously something that's the opposite. And then, so stiffness we talked about. You get a scar plate when you get granuloma formation, and when the mesh fibers are too closely together, there's a tendency for the stiffness, a tendency for the scar plate to build, and in the end, you have the rigidity of the mesh, and you may end up in a situation like this that nobody wants. All right. So, and also, I mean, there's a couple of other things that actually play an important role. I'm only going to touch on those. Obviously, infection is a primary concern always. when you put a foreign body into a human body, it's always because you're increasing the risk of infection. If you actually look at the studies and look at what's out there, it's actually well proven that the mesh, any mesh, is never the cause for infection, but it may elevate the infection, right? So if you have an infection, you put a mesh in place, what you're basically doing is you're providing surface for the bacteria to adhere to. So it's almost like a host. It becomes a host for the bacteria, and then the bacteria can grow and lead to an infection. But originally, I mean, if you look at the real root cause, the mesh is never the root cause of the infection. It just elevates the infection. Those effects, obviously, we have to also keep in mind when we make our mesh selection and look at the surface of the mesh, because the more surface it provides, the higher is the risk of any infection, because you have more surface for bacteria colonization. Okay, so if we just kind of like sum this up, it starts with a foreign body reaction, which is a chronic inflammatory response you always have when you put something inside of any one of us. And then also fibrosis, and then you see there's different effects on different things here that we need to make the measures. Okay, so the optimal mesh, and Dr. Konz is going to talk about it a little bit more tomorrow. When we select the mesh, there's different parameters that should be considered outside of the handling properties. It's really what's the strength, what's the porosity of the mesh, so is it large pore versus small pore or something in between. Obviously you want it to be elastic, so it does comply, say with the abdominal wall if you do an incision hernia repair, ventral hernia repair. You want to have elasticity. You want to watch the surface, and the weight probably today we say is less important. Looking at the weight is less important. Other parameters are there. So just, I don't know why this is animated. So it really starts, if you look at the mesh size, here's the things that kind of like we control in making those meshes, right? From the polymer we choose to the filament size and all kinds of things. It leads then to the mesh properties as they are listed here. And now if you include the foreign body reaction, or you want to reduce the foreign body reaction, here actually the parameters that are indirectly related to everything we do up here. So in mesh development we want to always keep those relationships in mind. So if you just look at this and the ideal or optimal mesh, however you want to call it, you want to have obviously sufficient strength because you want it to hold the hernia, especially if you have larger defects, you can't close the defect, you want to make sure it holds. You want to have elasticity, as we talked about. The porosity is going to get to the nice integration without the stiff scar formation. The low surface of the mesh material is good because of you providing less opportunity for bacteria to attach and adhere to the mesh, so that's good. And the weight, as we see, is not so relevant as a factor. Here's some measurements, and you see the study. So you've seen those data before. Basically, if you look at the maximum abdominal wall pressure, so pressure you can create inside your abdomen, through, let's say, coughing or jumping or pressing or whatever you do, you see that in terms of the strength of the mesh, each one of the meshes that's on the market today is stronger than the maximum pressure that you can have in the abdominal cavity. Some only have a little bit above, some are significantly above, but all of them are strong enough. So, I mean, they're all strong enough to hold the pressure. So here's actually talking about elasticity. This is actually something from Dr. Konz. You see how elastic the mesh is, how it nicely stretches. But more importantly, if you look at the left side here, this is the implanted mesh. The patient had to be reoperated for other reasons, but you see how flexible the mesh is. It's fully integrated and it's very flexible the way it moves. And that's the way you want to have it. That's the way you want it to comply with the abdominal wall. So that's an ideal situation, as you can see. You can move it around, it just moves like tissue to be. And on the other side, you see the other effect, where you see a mesh that's very rigid, a lot of scar formation that you see here. And yeah, that's one of those plaques that you don't want to have. Big difference depending on the design of the product. So just summarizing that part a little bit. We know today, based on scientific studies, that the abdominal wall stretches about 2 to 1 in this direction versus this direction. So we need to make sure we have the mesh design ideally very close to this. So when you move around with the mesh being implanted and integrated into the tissue, you want to make sure it moves the same way. So that's why today's meshes, most of them have what we call about a 2-to-1 stretch, so 2 times this way versus this way. Not so important in inguinal, obviously. There's not a whole lot of movement there. You don't need that elasticity there. But for ventral, you need it. So you want it to be elastic. Here's again a clear reach out to what we just talked about, right? If you have small pore meshes, here's the mesh fibers again, and like this one here, they're too close together, you get the bridging fibrosis, right? You get the granuloma formation, this one here, and that leads to the scar plate, as we've discussed. Not a good situation. If the pores are large enough, the fibers are apart large enough, the granuloma builds around here, but you still have distance, that's when you get to keep or maintain the flexibility of the measurements. Okay, let's skip over this. You've seen this before. So here's a couple of things about the mesh. In the past, we talked about heavy weight, and then we talked about the grams per square meter. Or we called it lightweight, and again we talked about the grams per square meter. I guess what we would say today, the relationship was lightweight used to be large pore, and heavyweight used to be small pore. That's not really true. I mean, there are a lot of exceptions to this. So today we don't like to talk about light or heavy weight anymore. What we like to talk about is the porosity of the mesh and the surface area of the mesh. Because if you look at the science, those are really the parameters that are important. It's not so much, if at all, the weight of the mesh. That's a term that we as a company probably are somewhat guilty of introducing when we work with Professor Schimpelik. But again, if you look at the new science and the data we have today, those are really not the right terms to describe the properties of the mesh and compare properties of different meshes. So we try to move away from this based on the science that we have today and talk porosity and surface. Okay, so if you put this all together, you can say in terms of tensile strength, basically all meshes are strong enough. We talked about this, we talked about the abdominal wall and the elasticity. We talked about porosity a little bit. We said because of the risk of infection, low surface monofilament is best. And we said the weight of the mesh in gram per square meters is really not a measure we should do. Okay, so this is just to sum it all up. You've seen this slide before. We just put the different parameters in. Okay, so skip over this. So this is basically was in a nutshell. I tried to skip through the 20 minutes I have promised. It's a little bit of the data and science. So based on evidence that we have today, that should help us. Should actually guide us when we have a dialogue about any kind of meshes. And as you've seen, there's no Ethicon mesh mentioned in here. Some Ethicon meshes fulfill those criteria. Some of the other meshes are less. It's not that this is not saying that we're the only ones who do this. We're just trying to have a dialogue with you based on evidence and based on data, and we use terms that are scientific terms to really compare and discuss the properties, and all you really get to an ideal mesh. We probably never have an ideal mesh, but as close as we can get to an ideal mesh, we'd like to have the discussion based on those kind of observations. Okay? So. A little bit closing, kind of like today's word, just 2 more slides or so on the future. And I don't know, I can't look into the future, so I can't tell you what the future of hernia surgery will be. I guess when we analyzed, we looked at this a little bit. Obviously, initially, hernia was all about recurrence. It was moving from a tension to a suture repair, doing a mesh repair, and the primary goal was to reduce the rate of recurrence, right? So it was like around 40% or something, depending on what you did. And now it's probably, let's call it single digit. I mean, there may be exceptions, but hopefully across the board it's probably below 10%. It depends on the procedure and what you do. Relatively low. So really today recurrence is not the primary issue anymore. Then, and this is the story of the large porous meshes, right? Then we try to make sure we actually design a mesh that is more compliant with the human body. And we spend a lot of time doing this, developing new generations, partially resolved materials, all those kind of things. So, and then where we are today is kind of here. I mean, today we talk a lot about pain, as I said initially, a lot about chronic pain. We're asking questions, okay, what's the pain related to? Part of that is mesh related, as we have seen. If you have the rigid mesh, the scar, that obviously is pain related. We do know that obviously fixation does play a major role, and there's being sutures, but as you know, there's also self-fixating meshes out there, right? Meshes that kind of like adhere to the tissue. So also the goal being to reduce the pain that we have. So that's where we are today. I mean, into the future, and I know we're doing complex repairs today. I put it into the future because, and also discussing with some of you before dinner, we really don't have a good solution for really complex, contaminated, whatever hernias. We really don't have a good standard of care. We don't have a good solution. We're using biologics in some areas. We're using different techniques. We're doing component separations. Some people say, well, if I have a contamination because I say cut into the bowel or for some other reason, I don't put a mesh at all. I close the abdomen, I ask the patient to come back half a year later. It's kind of all kinds of things are being done today because there really is no one way of doing it, no right way of doing it. So I guess in the future, all of us will have to still figure out what to do with really complex and complicated hernias because today we don't have a solution. And then I guess ultimately what we want to talk about is how about regenerative repairs, how about prevention, how about combining the mesh with something, be it an antibiotic or be it something else, right? Those kind of things will obviously also be discussed in the future. They are being discussed today, but again, this is just the beginning, I believe, of those discussions. So, and I leave you with, these are just a couple of questions that internally we're always discussing, and I'm sure you have the same questions, probably more. So again, what do we do with chronic pain? There's still a lot more to be done. No mesh is perfect today. We know it's not perfect. We know our meshes are not perfect. So what can we do jointly to make them better? How about hernia prevention versus treatment? That is something at every congress, you have a hernia congress, you have a session that talks about this. What can we do here? That includes the watchful waiting sometimes and all kinds of things that are being discussed. And then a big question of mesh placement in ventral hernia repair. I mean, should we be placing any mesh inside the abdominal cavity, right? The IPOM placement, so intraperitoneal meshes, should we do this at all, or is it much better to place it extraperitoneally in sublayer retromuscular position? I don't have the answer, but those are obviously questions that we need to think about. And then what goes with it is certainly the fixation. How should we fixate a mesh? I mean, do we need transfacial sutures? If yes, how many? Can we? What else can we do to get to a safe repair, but yet have less pain for the patient? And what's the right solutions? Do we need to close the defect or not? I mean, still talking ventral. Do we need to close the defect? Do we leave it open? Do we close it when it's say 6 centimeter in size, but when it's above we don't? All kinds of things. I guess we still have to find answers to those questions. A lot of discussions around tailored approach. So look at each individual patient and then say, okay, for this patient, I'm going to take this mesh and do this technique, and it's going to have this outcome. Versus standardization. I mean, there's organizations and people trying to standardize and put out guidelines, which obviously that doesn't go with the tailored approach. If we have guidelines, the guideline tells you, okay, if you have this case, it's classified like this, you should be doing this. Well, that goes against the tailored approach, right? It can go against the tailored approach. So we have to still figure out what's the right way to do this. Are both things right? It just depends. Or is standardization better than tailored approach or vice versa? I don't know. So there's a lot of things there. And this is interesting. Now, what's the patient involvement in the mesh decision? Is it going to be you for the next 50 years who tell him, I'm going to have this mesh and I'm going to put it inside you and here's how it's going to work? Or is the patient going to be more informed? He goes to the internet, he does all kinds of things, and he comes to you and says, well, doctor, please operate my inguinal hernia, but I want you to take this mesh. And then you get into that kind of discussion. I don't know if you have those discussions today. Probably not to that extent, but I'm sure they will come. I mean, they will come. I mean, if you have more informed people, you will have those discussions. And then what do we do then? And then obviously the statement down here is biologics versus bioabsorbable materials, macroporous permanent meshes. What do we do here? The more data we see, the more studies we see around really biologic meshes, they are actually not very convincing. There are a lot of people using biologic meshes. Sometimes you have no choice, that's granted. Sometimes you really can't do much else. But if you look at data and recurrence rates, I mean overall across the board, it's not very convincing. So the question is, what's the future of those materials? Do they need to be improved? Can they be improved? or do we need to maybe a synthetic bioabsorbable, something that is similar to biologic, but okay. Hopefully I kind of like didn't overrun my time too much. I wanted to close it here and say thank you for your attention. You came to have dinner, so hopefully some interesting stuff in here. So thank you very much.